Hello, everyone. Welcome once again to our discussions on gender equity and social inclusion in global health supply chains. My name is Miranda Buba Atare, and I'll be moderating our program today. I'm a pharmacist by training, and I've had experience for over 10 years leading public health supply chain programs in Nigeria. In my current role, I serve as the supply chain program manager on the UNFPA project in Nigeria. And I'm also an active leader of the IAPHL Nigeria chapter. I would like to introduce Dr. Taroub Harb Faramand and Yasmin Chandani, who will be our panelists today. So, Taroub.
Hello, everyone. It's a pleasure to be here. I'm really delighted. My name is Taroub Harb Faramand. I'm a physician by training. I worked as a clinician for 17 years before I moved to working entirely on public health programs. And during my work as a clinician, I managed the health work in different refugee camps, including health supply chain. But then I moved to senior leadership positions as a direct USAID staff member, as a chief of party, and as a director of global health programs. And now I am the president of IAPHL, which is a very small women-owned small business providing technical support and services globally. Thank you so much, Miranda, for inviting me to be with you here today.
Thank you, Taroub. We're very privileged to have you. Dr. Chandani.
Hello, everyone. Good afternoon. Good morning. My name is Yasmin Chandani. I lead the inSupply Health team, and inSupply Health is an East African advisory firm. We specialize in supply chain health systems, and we're headquartered in Nairobi with an office in Tanzania. We're affiliated with GESI, and my background is in supply chain. I've been working in supply chain for over 20 years. I started when I was 5, and I've worked across mostly sub-Saharan Africa, but also in Asia as well, and worked across a variety of different supply chains, and now have the privilege of leading a team here in Kenya and Tanzania as we work with our partners on the ground. We have a mission that's focused on the last mile of supply chain and serving communities. And I also want to thank you for inviting me, and it's such a privilege to be on this panel. Thank you very much.
Thank you, Yasmin. It's a privilege to have you, and we look forward to what you have to tell us, your experiences. We look forward to hearing them. So before we proceed, I would just like to ask participants to please use the chat function to ask any questions, and then we will address those questions at the end of the discussion. So moving on quickly, I would like to introduce Tiffany Marshall Cummings, who will be giving us an opening remark. Tiffany is a global health professional with over 6 years of experience in program management, country backstopping, advocacy, outreach, procurement and supply chain management, as well as a technical resource for family planning programming in West Africa, DRC, and Burundi missions. She's an analyst too, and the West Africa country team lead in the Division of Commodity Security and Logistics within the Office of Population and Reproductive Health at USAID. You're welcome, Tiffany.
Thank you so much for that introduction. Good morning, everyone. Thank you so much for joining today's webinar. I'm excited to see the participation in this room with, I think, 33 attendees representing an array of organizations. This meeting and your participation exemplifies this community's commitment to advancing gender equity and social inclusion within the space of health programming, commodity security, and supply chain. In supporting country governments, civil society, traditional and non-traditional stakeholders, USAID seeks to deepen the focus of intersectionality, accountability, local leadership, and gender transformation by addressing the structural sources and the root causes. Doing so can intensify impact, improve health outcomes, and advance health systems. My division, the Commodity Security and Logistics Division, has a mission, which is to ensure that long-term availability for clients of a wide range of high-quality contraceptives and family planning and reproductive health commodities for public and private sector. Within this space, and as thought leaders, we intend to use our ability to move and inspire action through meaningful and impactful coordination among partners to further strategic supply chain thinking and push the envelope in how aid is provided for commodity support and technical assistance, which is also what we see here in this community today. Everyone in this virtual space is here today to advance the thinking and push the needle around social inclusion and supply chain and to catalyze transformative change. The USAID agency seeks to emphasize gender as a social construct that highlights the rights-based justification for prioritizing gender equity alongside benefits to broader, sustainable, and inclusive development, as this is to be a shared view with this community for which you're a part of. So let me close by thanking you for your participation, for your engagement. Thank you to our phenomenal presenters. And everyone who worked behind the scenes to make this meeting successful. With that said, I'd like to turn it over to Miranda.
Thank you very much for the opening remarks. Taroub, if you could proceed, would appreciate it. Thank you.
Absolutely. Thank you so much, Miranda. Again, I thank you for inviting me. I am so delighted to be with you here today. And I'm interested and excited about sharing with you our experience in gender equity and social inclusion. More specifically, I will focus my talk today on integrating and mainstreaming gender equity and social inclusion in health supply chain. I will start by briefly describing our IDARE methodology. So IDARE is an innovation that we came up with and have been implementing for the past 10 years. And it is based on the science of improvement, behavior change theory, and design thinking. We use IDARE to support local professionals in different countries to identify and address gender equity and social inclusion gaps affecting program outcomes in a variety of sectors and also at all levels of service delivery, starting from the community to the national level. IDARE allows us to remove the power dynamic from the words strengthening local capacity, because we hand over tools and processes to our colleagues in different countries, and they are in the driver's seat to make change happen for their own countries in the best way they see fit. The first step of IDARE is the identification of gaps and barriers. And we, as I mentioned, work and support local professionals to use data for that purpose, whether the data is in existing systems or whether they need to conduct rapid assessments to find the data to be able to identify those gaps. So data is at the core of IDARE. Using data is at the core of IDARE. The second step is to design and identify locally contextualized solution. And this is an important process in the localization, or an important step in the localization process, I would say. Designing local solutions is critical because local professionals in different communities, different countries, or different parts of the countries can design solutions that work for them. And as we all know, not every solution leads to an improvement. So it is critical and important that those solutions are locally identified and also locally implemented to enhance buy-in, to enhance commitment, to enhance accountability, and making sure that people basically are excited about their own solutions that they're identified. In designing those local solutions, we adhere to the no harm principle, the do no harm principle. And this is also critical because sometimes when we identify solutions to address gender equity and social inclusion, we might, with unintended or without intentions, if you will, implement solutions that might cause harm to a certain group of people. We therefore, in designing every solution, we encourage our local colleagues in different countries to ask themselves and check whether the solution that they identified might harm a certain group or a population. The third step in IDEA is to implement those solutions and to continuously monitor whether the solutions are working or not. As I mentioned earlier, not every solution leads to an improvement. And this iterative process has to go, it has to be, continuous, because we don't want to wait for a whole year to realize whether the solution is working or not. And if it is not working, we ask, why not? And we keep encouraging our colleagues to unfold the reasons and to understand why, to adapt the solution. And this will allow local professionals to continuously adapt and learn, and to continuously also be accountable for the adaptation. There's a lot of learning embedded in this process. Then we encourage, the fourth step is to record what happened, whether the solution worked or not. If it's successful, we expand. If it is not successful, it is retired. There is a two-way learning process. As I mentioned, we remove the power dynamic from the words local capacity strengthening. And then the fifth step is to expand to other regions or other parts of the country. Next slide, please. So this is IDEA. Now I would like to just go over some definitions to make sure we are all on the same page when we use the words gender equity or social inclusion. So what is gender equity? It is the process of being fair to people of all genders. And I realize and I understand, based on also our experience working in the field for the past 10 years on gender equity and social inclusion, there is some tension around the word gender. As we all know, gender is an English word that doesn't have the exact translation to other languages. So if you just Google the word gender in other languages, it means either kind or type, but we don't have the word gender in other languages. We therefore can just use the word, we want to be fair to all people. We want to make sure that all people we are have the ability to basically use and exercise their rights. As Tiffany mentioned, it's a rights-based approach. Exercise their right to be an active part of their community, an active part of their existence in this world. So we want to remove those barriers that affect achieving this term equity. Social inclusion, it's a deliberate act of welcoming diversity. So we want to bring people in, and we want to create an environment where all different people can thrive and can succeed irrespective of their status or identity. Next slide, please. So I want to also share with you what is equity and equality, just because we many times use the terminology interchangeably. As you see in the graphic here, when we talk about equality, we aim to achieve fairness. So in the graphic on the lower left corner of the illustration here, as you see two people having the same tool, we have the same ladder. So this is equality. Equality when everybody has the same tool or the same, the same situation regardless of their needs. So they have the same. As you can see here, the tool on the ladder on the right side of it is not allowing the person to pick fruit from the tree. What is equity? Equity is when we achieve fairness. Achieve fairness by treating people depending on their needs. So as you can see in the upper right corner of the graphic, you see different ladders here, just because we wanted the person on the right side to be able to pick fruits. So this is equity. And just as when we remove all barriers, so people have the same tools, they have the same access, we remove all barriers, and everybody will be enjoying justice in this world. Another quick example is equality. When we talk about equality, means everybody has the same shoes, but equity is people have the shoes that fit their feet. So that's another quick example that we sometimes use in our trainings. So I hope this clarifies the difference between equity and equality, and equity helps us achieve equality. Next slide, please. So when it comes to social inclusion and intersectionality, what is social inclusion? As I mentioned, we want to bring in people diverse and accept diversity regardless of where people come from. As you can see in the graphic here, people might be excluded from society or from the community based on different situations or different factors that affect them becoming part of the society. They could be unemployment, it could be financial problems, it could be age, it could be education, substance use or misuse of alcohol and drugs, it could be physical or mental illness, and so on. Well, intersectionality, we use this word also a lot. It's how all identities, whether gender-related, age, race, ability status, health status, sexuality, religion, and so on, affect our experience in this world. Sometimes also we think about how can we address gender separately, and so how can we address, for example, ability separately. We need to make sure that sometimes ability, gender, or age, we have intersectionality between different factors. So it could be something affecting a woman that is dealing with ability-related issues that basically is uneducated. So there is intersectionality between those factors that also affect programs that we are trying to accomplish improved outcomes in those programs. Next slide, please. So now I'm going to focus more on gender equity and social inclusion in mainstreaming gender equity and social inclusion in supply chain. So sometimes we use the words mainstreaming and integration interchangeably, and I would like to clarify the difference between the two terminology. Gender equity and social inclusion mainstreaming means that we are addressing those factors at the institutional level. What do I mean by that? It means that we, for example, address gender equity and social inclusion related issues at the HR level, in the hiring process, in designing job descriptions, in making sure that our colleagues or our professionals working with us in supply chain have access to resources. All of them have access to resources. We invite people who have historically been excluded from the sector to join the sector. How can we encourage that? We make sure that there is improved working condition, that the motivation process allows all genders, all people from different groups to be able to exercise their rights, to enhance their ability for improved performance at the work level. So this graphic you are all familiar with, and we used it because you know it, and you have this commitment, as Tiffany mentioned, to address gender equity and social inclusion in the workplace. When we did the online discussion about gender equity and social inclusion in supply chain, an interesting point that we noticed that the discussion was mainly focused around mainstreaming gender equity and social inclusion. And I will share with you some examples now about how we look at it. Next slide, please, Rachel. So for example, when we talk about staffing, are the job descriptions written to reduce biases? And are the job descriptions written to encourage a diverse group of candidates to apply? Are they being designed to exclude also? If you read the language, when people read the advertisement, do they say, "Oh, I cannot do this job," or "I cannot perform because of the way the job description is written"? In terms of skills, do skill-related trainings that are offered in the workplace in supply chain reinforce or challenge gender norms, for example? When From our experience working on addressing mainstreaming issues related to gender, we as people, come from different communities, different backgrounds. We are ourselves affected, so we have our own biases. And when we offer trainings, we sometimes unintended, or without intention, might cause additional reinforcements of gender related norms in the workplace. What about working conditions? Are we allowing our colleagues working with us in supply chain to have safety in the workplace or to feel safe? There are two ways here. We talk a lot about harassments in the workplace. We talk about sexual harassment. We talk about a variety of harassments also in the workplace that affect the safety, the feelings of our colleagues to be safe. Another issue that not only women, it affects also men. There are issues related to reinforcing existing understanding of the role of men in the workplace. The stigmatizing men, for example, if they ask for help or things of that sort. When it comes to motivations, are rewards for performance equitable? Are they accessible? Are they relevant to workers from a variety of backgrounds? So we need to think about when you apply this framework in building human resources for supply chain and in thinking about this theory of change, think about those examples related to the four areas that we are discussing today here. And Yasmin, my colleague, will share with you some examples how their project addressed those issues. Next slide, please. So when it comes to integration, we're talking about integrating gender equity and social inclusion in the program itself. So with mainstreaming, it's at the human resource level, at how we encourage the mainstreaming to encourage people to join us in supply chain. And when we integrate GESI in programs, we integrate it in the supply chain management cycle, for example. So we identify specific gender-related or social group-related differences and resulting inequities or inequalities. We address the differences in the design. As I mentioned, we use the second step of IDEA when we design programs to make sure that we have equitable solutions when we identify budgets, when we implement the program, when we capture our indicators, gender sensitive, and so on. Next slide, please. I'm going to give specific examples here, and this is my last slide when we move on to my colleague Yasmin, so she can share real examples on the ground. So when we, these examples are related to the supply chain management cycle. When we serve our customers, we think about different areas in serving our customers. So we ask ourselves, have we considered all customers? When we talk about gender, age, ethnicity, race, income level, social status, different religious groups, the ability status is very important. When we talk about product selection, for example, do products we select meet the needs of adolescent and young people? So when I am talking about those examples, I would encourage you to start thinking about your program, because you might be implementing those activities without having a label on them like gender, equity and social inclusion labels. So start thinking about that, because when we go to the breakout room, we will continue the conversation about those examples. When we address quantification, have we accounted for variations in product needs based on immigration, on seasonality, on populations that keep moving from different parts of the country to another as pastoralists, other factors that affect the population size and demographics? And this is a very important factor. I worked a lot in reproductive health and family planning, and I worked a lot also on identifying contraceptive needs for different populations, and this is a very important factor that I need you to think about. When it comes to warehousing and distribution, for example, is there physical infrastructure in place to transport or store commodities needed for management of abilities, for example? In designing inventory strategy or in thinking about the strategy, does the inventory strategy consider diversity in products, in availability, for example, contraceptives, as I mentioned like a few seconds earlier? Are they having, do they consider social inclusion effects? Do they consider gender-related issues? In procurement, are gender or social inclusion factors integrated into the procurement process and guidelines? So when we talk about gender here, I need you to think about men and women. I need you to think about factors like LGBTQI. I know this is a very sensitive issue in different countries, and we address it constantly when we conduct our trainings, but I need you to think about the different groups in your community and how you are addressing it. If you want to remove the word gender from your discussion and you want to talk about different groups in your community, that's also fine. So this is my last slide, and I would like to turn over the discussion to Miranda now, and then to Yasmin, so she can give us real examples from, or real world examples. Thank you so much, Miranda.
Thank you very much, Yasmin. It was very illuminating to hear about the IDEA methodology and to learn about the differences between equity and equality. And to have you explain to us the difference between GESI mainstreaming and integration with those general examples. And next, we would like to hear some specific examples from Kenya, from Yasmin. Over to you, Yasmin.
Thank you so much, Miranda. And good afternoon, good morning again, everyone. Thank you, Taroub, for laying out the framework so clearly, as Miranda said. What I will do now is share two short case examples from our work at inSupply of how we were able to integrate GESI considerations into our supply chain strengthening work. And I did want to note that to date, inSupply's work has not been gender intentional or transformative. This is changing as we move forward, but the results I'm sharing now were not necessarily because we were able to take a gender intentional approach. And the reason I want to share these examples is because I believe many of us might already be implementing aspects of gender and inclusion in our work, social inclusion. And these examples might offer ideas on how we can all build on the work already done and learn from each other as we build up, the gender mainstreaming and intentionality into our work. I'll start with an example of mainstreaming and follow this sort of same framework that Taroub did, mainstreaming and then talking about the country-specific integration. So the example I'm sharing relates to some work around impact teams we've done in Kenya and Tanzania. Impact teams are a continuous quality improvement approach that promote data use. And these teams tend to be operationalized at a district or a sub-county level. And they target managers who are the front line of supply chain management, but they may not be equipped to use data continuously to improve their supply chain performance. And these teams are often made up of multiple cadres, pharmacists, clinical officers, nurses, and they're all responsible for different supply chain tasks and roles. And we, through these impact team approaches, build up their agency to use evidence to address supply chain problems. And I'm going to talk today about one component of the overall impact team approach, which is the learning packages. This was a strategy we deployed to empower capacity of all team members, whether they were men and women. And this is why we're sort of using it as a mainstream example. So if we go to the next slide, we conducted human-centered research and design to understand how to build more effective and sustainable impact teams by learning about the problems and potential solutions from their perspectives. And through this, we generated 7 role profiles that are essential for operating an effective data use team. So these role profiles embody the essential knowledge, skills, and behaviors for effective data use teams. If you look on the slide, the ones on your left, the 4 are designated as core role profiles. They are required to participate routinely in the meetings. And the other 3 are enabling role profiles who make sure that the impact teams have the leadership support required. They don't need to be accessible as frequently as the core role profiles do. And I just wanted to point out a few things before I go into the learning packages. Please note the intentional gender balance between the role profiles. Even without intending to do this, we did try and address some of the stereotypes about the roles men and women play. For example, some people might consider women not strong in data or strong leaders. Our role profiles are female in this regard. What we were trying to show is take the focus away from individuals who play those roles and really note that anyone can be a positive agent of change and can play these roles. So the focus was to ensure that the teams understood these role profiles were about skills, behaviors, and competencies, and working together effectively as a team, not about the individuals on the team. So one person could bring multiple role profiles to a team. And the way it works is that we have an assessment and they self-assess as a team, and then they develop their individual and their team learning goals and journeys. So if we go to the next slide, this is essentially how our learning packages were born. We realized, and I think I want to share the learning packages because this is how these are where some of the examples of how to address gender and social inclusion might come from. So we realized that these frontline supply chain managers needed specific skills to do their jobs effectively. And through the human-centered design and research, we identified many common barriers they face. So many team members are busy healthcare providers. They juggle multiple responsibilities. One example might be a nursing officer who's an EPI logistician or an RH coordinator or both, and who's also a wife and mother. She may not have time to go attend a 5-day training far away from her post. She may not be selected for that training for a variety of reasons. And while she knows that there are supply chain courses out there, they're costly for her and maybe not within her means. And this goes for men and women alike. Many of these providers are busy. They often have to firefight as part of their role, and that takes away their ability to be strategic about learning and building up their capacity. Yet by building up the capacity, they could do their role better. They don't have large blocks of time to spend learning. They might have a few minutes at home or when they're in transit, maybe 15, 20 minutes. They only have access to a mobile phone or tablet when they're at home rather than a laptop. And all of them are motivated by the idea of doing better and acquiring certificates, which could help them in their career progression. So we designed learning packages to be self-directed, online, modular, and really for building competency in the improvement of data use for health supply chains. So not necessarily general skills, but very focused on a specific skill set so that these men and women could actually learn those skills very rapidly, apply them and see the benefit in themselves and their skills as well as the work they're doing. And we built in this user-friendly design so that they can be practical and so that they meet those users' needs. If we go to the next slide, so we essentially applied these learning packages with men and women from 43 impact teams across Kenya and Tanzania, and you can see even within Kenya, they were very mixed, very diverse contexts within Kenya, and we got feedback from actual users on these really important aspects of inclusion that I mentioned. We had about 200 learners and issued over 300 certificates, which meant learners were, and we didn't pay them for this learning or anything. This was all self-driven, but obviously learners got more than one certificate on average. And the feedback we received included that they are a self-directed method of learning for health workers that is user-focused, easy to use, effective and flexible. And this was really important for them for their busy schedules. So they are ideal for busy healthcare providers. And most importantly, the self-directed nature made them accessible to a broader audience. So this is where the inclusion comes in, helping to break down the gender and social barriers that usually limit certain categories of health workers from accessing these skills, either due to time or financial barriers. And then the other piece of feedback we got that we found interesting is that the current modules are equally focused on specific needs or skills, so supply chain, data, as well as universal needs, such as problem solving and organizational competencies. And these universal modules were relevant and helpful to health workers who are constantly juggling roles and responsibilities at work and at home. So they very much appreciated that. So that's the example I have of more of the mainstream kind of lens we've taken for gender and social inclusion. If we can move to the next slide, I'll now share a more specific example of how we were more intentional and focused for improving equity in the community health supply chain, specifically with a focus on digital health. And my example is coming from Kenya. It's an example really of gender and social inclusion. Kenya's rapidly digitalizing its health information systems, including for supply chain. And this case study will take place in the northern areas of Kenya. It's a region called the ASAL region, the arid and semi-arid lands. And they're some of the most hard to reach areas in the country. They're also characterized by some of the poorest health indicators. So if we move to the next slide, we have a solution called CStock. It's an approach actually that combines resupply procedures with mobile technology, user-centered dashboards, and again, the impact teams I talked about. It was deliberately designed for community health volunteers and successfully implemented in Malawi in over 3,000 of them, and about 1,000 in a mainstream county in Kenya called Siaya County. And through the Siaya experience, the Ministry of Health was really excited about CStock. They currently don't have a commodity management system for CHVs. Universal healthcare is an important goal for them, so they really wanted something that could help CHVs effectively manage their supply chains. However, the challenge that we all faced was that it was unlikely CStock in its previous iteration would work in all 47 countries, especially these ASAL regions, where there are big challenges that we'll see on the next slide. We were very fortunate to get a grant from the Bill and Melinda Gates Foundation that specifically focused on equity of access to family planning and contraceptives in these areas. So if we go to the next slide, just a little bit about some of the challenges and gaps in gender and social inclusion we were trying to tackle. And we had to address them generally as well as specifically in the adaptations of CStock and the approach. So you'll see that some of these issues represent gender equity issues such as low literacy and numeracy. This affected women more than men. The inadequate human resources. For example, while family planning is not a program that only targets women, it does largely speak to women's needs. That human resources there were far more constrained than they were for other services, for example. Mobile phone ownership is something that we found bigger gaps for women owning phones than we did for men. Women often had to borrow their spouse's or a friend's phone to be able to use it. They didn't have their own. And something like unreliable supply chain procedures and processes. I think this is an example of perhaps social inclusion where CHVs, because they're volunteers, they don't have a voice, they're not empowered, they're not paid, they may be taken for granted. The system is not designed specifically for them. It's designed generally. And so this was another gap we identified. Other social inclusion problems were the low network connectivity, which affects that part of the country, the vast distances. And the data you see at the bottom just shows how CStock performed prior to implementation in these areas. So we knew that it worked, but we needed to, the challenge we had ahead of us was, how do we make CStock appropriate, accessible, and adaptable for these communities in the North, keeping in mind these very specific gaps that we've discussed. So if we go to the next slide, we worked through this, the project was called the SCALE project in 4 countries, Samburu, Turkana, Wajir, and Mandera. And we used, again, human-centered design to give communities a voice in articulating their problems and the potential solutions. So for the next 2 to 3 slides, I'll cover what the form that some of those solutions take. But, you know, in our research, we heard so many examples of some of the gender and social inclusion barriers that they face. I've mentioned some of them before. One of the ones I wanted to just say is, you know, these communities are disproportionately affected by natural disasters and climate change. One of the things that happens is that when these natural disasters and climate change happen, they have to deviate from their predictable migratory routes. They have to look for food and water for their families, for their communities. So one of the solutions that you can see on the slide is actually adapting the design of the supply chain itself, and even the permissions in the national health system to allow these CHVs to get resupplied while they were on their migration routes from the closest health facility, instead of having to go back to the designated health facility, which might be very far away. And we also made accommodations for the different forms of transport, as you can see, that they might have to use. Next slide, please. Some of the most evident adaptations we made were about phone ownership, because CStock uses mobile. It's not only a phone solution. It also looks at the other things I talked about, system strengthening, teamwork, but at its basis, the data is transmitted using a phone. And as I've mentioned, women tended to have less ownership of phones, and also with the network connectivity and the types of phone, we had to really be inclusive in our design. So the ways we did that was, first of all, for those that did have Android phones, but where literacy and numeracy was still an issue, we used icons and we included voice prompts in the app to help them very easily understand the commodities they were going to report on, and also what they were reporting on, whether it was stock on hand data or receipts, something like that. But we also redesigned CStock to be possible with USSD and feature phones. The vast majority of CHVs use feature phones because many reasons. They hold a charge longer, they're more robust, they're resistant to dust. They actually catch the network better than Android phones. And so USSD was a really good choice for them. And it also addressed some of the literacy issues, because with SMS, you have to know how to type and get the spaces right. USSD, you use a menu. Another way we created an adaptation, I'll actually talk about this in our next slide, so I won't talk about it now, is that using pictures to digitize data. But I'll go towards the right-hand side where you see a series of screenshots. And that's another part of the solution we designed, which was what we call the Char Portal. The Char is the CHV supervisor. And what we said is, in a situation where CHVs are completely unable to report for whatever reason, can their supervisor be a support to them? And this had the added benefit of addressing the issue that CHVs felt very excluded from the health system. This was a way to connect them and the supervisor more closely. So we created a Char Portal that decentralized the management and really put the Char as the true supervisor of managing CHVs. And then they made the decision together with the CHV whether or not the CHV reported or they reported. So there's a delegated reporting feature. And it also allowed quality reviews to be done of the data submitted, which you'll hear later was a really important part of inspiring trust from county managers in the ability for CHVs to actually manage commodities, because before this, there wasn't a lot of confidence and faith in that. If we go to one of the things that we learned, unfortunately, we discovered with the Char Portal is an unintended consequence, and I'll talk about what that is. But what we realized is we shifted the responsibility, the time burden, from the CHV to the supervisors as we created that Char Portal. And if you look at the next slide, I think you've jumped 2 slides, if you could go back 1, just to note that when we did our human-centered design research, we documented the day in the life of a male and a female CHVs. And we just put the one, in the interest of time, up for the female. As you can imagine, it's a lot busier than some of the male CHVs. And you can see the real combination of household, livestock, as well as professional responsibilities they had. Many of them had very long days. Just wanted to highlight this because one of the things we also strive to do with CStock and the whole approach was to reduce the time burden and time poverty of some of these women, and acknowledge that from a professional perspective, they still wanted to feel connected to the health system. They wanted to feel competent at their job, even though they didn't have very much time for group activities, for trainings, and things like that. So if we go to the next slide, I can talk about the then follow-on solution we implemented to address the time burden associated with the Char Portal. So we partnered with an innovator in Kenya called HealthyNet, who has a paper to digital innovation interface. And what we did is we designed paper forms that relied on bubbles and icons so that the CHVs could quickly fill out sort of their dispensing records or whatever it was on a monthly basis. They just circled a bubble every time they dispensed something. And at the end of the month, the CHV could take a picture of the form using any kind of phone. We pushed the technology. It was always working on smartphones, but we pushed it to work on smart feature phones. As you can see in the picture, it's like a feature phone. They took the picture, it was immediately digitized, converted to data, and the CHV supervisor received their stock data and was able to move ahead with resupply and other operational responsibilities. Next slide. So just a little on the next two slides about some of what we were able to achieve through this approach. We were able to essentially address some of the gender and social inclusion gaps all the way from the individual to the county, which is the subnational level, and the national level. At the national level, we used a participatory evaluation approach called developmental evaluation, which required ministry and county to actually make sense of the data themselves and make recommendations. And through that, they used the project learnings to expand the community health strategy nationally to be more inclusive for CHVs and to accommodate these nomadic hard-to-reach communities. They also expanded the criteria for digital health to include smart feature phones, and they integrated CSOC into the national system, all of which we felt was really a victory for social inclusion and gender issues from a policy and sustainability perspective. And then at the county level, as I mentioned previously, the experience of CHVs being able to report consistently, which you'll see on the next slide, really inspired confidence in county managers. The policy had always said that CHVs were allowed to manage commodities and do community-based distribution, but there was never any confidence, and this now changed that confidence level and allowed them to manage commodities. So if we go to my last slide, this just shows a little bit about the reporting rates, which after the initial launch remained relatively high. There was some dips when the project ended, that's the dark line, but you can see that generally reporting rates remained high. This was for over 3,000 community health volunteers across Kenya. And just to say that we believe a lot of the reason for the continued reporting is because it fulfills a need in these community health volunteers, and it addresses some of the most important pain points, which is what I think we hope we can all do through gender and social inclusion approaches. Thank you very much, and back to Miranda.
Thank you very much, Yasmin. Those were awesome examples of great work that you have done. I'm sure that we see that we may not be approaching our health supply chain work through a GESI lens, but seeing your specific examples, we can see that we already incorporate some of those aspects in our work, and we can already start to think about the gaps and how becoming more intentional will help us to address those gaps and make greater impact. So thank you so much for those examples, both at the mainstreaming level and integration. So we will be able to have a broader discussion with participants through the breakout rooms. So we'll have a couple of breakout rooms where we'll be able to discuss and hear your thoughts, specifically about whether there are issues related to gender equity or inequity in your program implementation, and as well as social exclusion or inclusion issues, and for which groups, and how we might integrate considerations for equity and inclusion to address those issues. So if we go into those discussion rooms, the breakout rooms. We look forward to hearing your feedback.
Okay. Hello, everyone. We are a group of 7, which is great. We can then have a good discussion. We only have 10 minutes, I suppose, correct, Rachel?
Yes, we'll be ending at 9:05, so about 10 minutes.
All right, perfect. So let's be as efficient as we could be. We had thought we would allocate 20 minutes for this session, but it's fine. We were a little bit delayed, and we have enough time. Can we maybe just quickly introduce ourselves to each other? And if you can tell us which country you are working in and what program you're working on. So I can start. You know me, Taroub Faramand. I presented today in the plenary. I'm the president of IAPHL. I'm going to ask maybe you, Walter, to go next, because you're on my screen as.
Okay, I'm Walter Proper and the executive director for IAPHL. And I guess now working worldwide, but I've been very involved in different countries, especially Zambia, for quite a bit of time.
Thank you, Walter. It's a pleasure to have you, Maria.
Hi, everyone. My name is Maria Barrow. I am an intern for YHER, and I'm here to take notes. I am a graduate student at George Washington University, and I'm excited to have this discussion with you all and hear your insight and how we can move forward with integrating GESI into supply chains.
Thank you, Maria. Rachel?
Hi, everyone. This is Rachel Simon. I'm the Global Community Manager for IAPHL, and I'm super excited to hear what everyone has to say today. Thanks.
You're welcome. Thank you so much, Rachel. So Clarence, I have Clarence next.
Hello, everyone. My name is Clarence. I'm a pharmacist from Zimbabwe. I'm interested in hearing your points towards this matter.
It's wonderful. Thank you so much, Clarence, and I'm looking forward to hearing from you. Okay, I don't know if it is the internet or what's going on. Let's move on to premises.
Hello, everyone. My name is Premis Kayembe from Chad, origin DRC. I'm a vaccine management specialist. Thank you.
Thank you so much for joining us. So let's jump in and talk about, I would like to hear your thoughts directly about issues related to gender equity or equality in your program implementation, or inequity, let me say, in your program implementation. So I'm happy to hear your thoughts about either mainstreaming at the institutional level or about integration at the programmatic level. If you can give us some thoughts, I'd like to hear your thoughts. Yes, please, Walter.
Oh, I would just give some of my experience in Zambia, and I would say I remember being in discussion when we were helping the central medical stores and look at their drivers. Mm-hmm. And we said, could there be a woman driver? And they were just emphatic that just wouldn't work. Although they had a very top official, their head pharmacist is a woman. Yes, had a very senior position, but they could not see that a driver could be a woman. Yes, and so we were pushing for them to maybe open up on that and see if, as applications came in, if they could have a woman driver, why couldn't they? But they still had that bias, even though they were used to very senior women in their organization. It was interesting.
Yes, I understand that aspect, Walter. We faced the same situation in Uganda about hiring a female driver, but it was very much welcomed by, we went ahead and a female driver was hired, and it was very much welcomed by the women colleagues on the project, because they would go to the field, 6-7 hours sometimes in the car, and they felt much more comfortable with a female driver. And I can understand that. Also, there are issues that some countries face with hiring women in a night shift or at night. For example, in Jordan, there is a law that prevents women from working in jobs that require them to be there at night. It's a law, by the way, that now is being worked on to address it. except for women who work in the medical field, like either nurses or doctors. But other women are not allowed by law to work on jobs in night shifts. So have you faced any other issue that you might think of, either at the level of either hiring or leadership, or also in the program that you are implementing? Walter, you still have your hand up. Would you like to say something else?
No, I'm okay. I think we should get someone else to talk. Yeah.
Yeah, I would like to hear your
Okay.
thoughts. If you didn't face anything, just tell me, like tell us that you didn't face it or you didn't think about it. Or, you know, the purpose of this is to just generate some discussion around those issues that affect men and women differently. Are there, for example, issues affecting men in your programs, like safety-related issues or issues related to how we view the role of men? Are we stigmatizing men if they express their views about safety, for example, because we have perceptions that men are strong and men can do everything and then they can handle any situation? I really would like to hear from our colleagues in the countries. If you would please share your thoughts, I would love to hear your thoughts. Like Clarence, you mentioned you are very interested in this. What is interesting to you in addressing gender equity and social inclusion?
Hello. Okay. So
yes.
Back to the issue of men in the workplace. I have noted where I work that many people tend to end up suffering from issues like depression because they can't voice out their concerns. So some men experience abuse in the workplace, but because of the all right, for example, I grew up in Zimbabwe. Basically in Zimbabwe, the way we were taught is that the man is supposed to be the supplier, the provider, the solution to all the problems. So a man is not really expected to voice out any concerns and any worries. You know, we don't expect that from a man. So you end up seeing a lot of depression, in cases of depression and all that.
Absolutely, Clarence, this is a very important point when we address gender. We don't talk only about women. We also discuss what men are facing and how can we remove barriers and address issues that affect also men in the workplace. So this is a very important point, Clarence, and it is a challenging point because we have to work at different levels of service delivery, or to address those issues with men facing challenges in the workplace. We have to do, when we use the methodology IDEAR, we work with local professionals, with our colleagues, to have a discussion around how can we address this. So Clarence, in your opinion, and I don't mean to just ask you, but because we started the discussion, how can we think through addressing this issue in particular to make sure that men feel safe and feel heard and feel comfortable in the workplace? How would you suggest we address this issue?
Okay. I'm not sure about the areas where you are, but I'll speak in the context of where I am.
Yes, think definitely in Zimbabwe. Yes.
I think if things like therapy became more mainstream, you will notice that in Zimbabwe, therapy is not really mainstream. In fact, if someone is saying, normally in Zimbabwe, right? If someone is saying I'm going to a therapist, they are stigmatized. They are viewed as someone who has a mental problem of sorts. So I think if there are more programs that will help maybe make therapy more mainstream and try to educate people so that it becomes a bit more socially acceptable.
Yes,
I
thank
think
you,
that
Clarence.
a long way.
Yes, and as this is a very important point and a big issue that needs to be addressed not only in the workplace, but also at the level of the community first, and then expanded to other service delivery areas. But as a professional and a leader in your own way, maybe you can start discussing this issue with your colleagues, and maybe we can have another discussion on how to start addressing this important issue. I really appreciate that you brought up the issue of men in the workplace and how we can address them being safe and comfortable. Thank you. I really appreciate that, which is very important.
You're welcome.
Thank you very much, Taroub and Tiffany. So I was wondering, Rachel, if you had some feedback from our group. We had some very interesting points from our participants.
Yes, absolutely. Thank you, Miranda. Yes, so in our group, we did have some very interesting inputs related to question 1. Ken shared that related to system strengthening, that sometimes the government does its own hiring, so there's really no direct influence on controlling that. So sometimes there may be limitations with having champions for gender equity in program implementation. The other was our colleague David Wander contributed that competing priorities can also affect what support is given to addressing vulnerable populations or gender equity. And our third one is sometimes working with marginalized groups. In this example, it was Kenya's arid lands. Implementing some populations might be might take more time to yield results. So implementing partners might be hesitant to working on social inclusion, specifically with marginalized groups that take more time. So thank you to our group for their contributions.
Thank you very much, Rachel, and the group participants. Is there any other feedback from any of the groups that someone would like to share?
Yeah, I don't mind jumping in and just in regards with our group. So we kind of took a different take to like the first 2 questions. We actually focused on what we have seen in a positive light. So for example, in relation to question 1, it was noted that in light of during time of COVID, noticing that there's more women who are participating in training and becoming more informed, especially in relation to the work that we do, and that they're able to have the time to commit it and be well engaged into the work with our programming. In relation to question 2, there was one colleague had expressed seeing that they're seeing way more inclusion compared to the past, and that you seeing, especially there seems to be an intentional focus regarding women, people with disabilities, and race, and so hopefully that will remain and continue. And then in regards to adjusting for question 3, it was raised that we need to be more in light of what we're discussing about gender intentionality, but to be more intentional regarding the embedded criteria into our programming and so forth, and in the design, so that that's an area that we need to focus and enhance more, as well as extend and committing to the work on changing the culture aspect too, because aside from technical piece and the work that we're doing to ensure that we have inclusive society, but as far as the workforce and the work culture, that it is also emphasizing that regarding that openness and inclusion to ensure that what work is being done actually sticks.
Okay, thank you very much for the feedback. That really sounds like very interesting, useful contributions from the group members. I see raised hands from Taroub and Maria. Taroub, would you like to go first?
Let Maria go first, and then I will go next.
Yeah, so our group had a wonderful discussion that kind of led us in two different directions. First, noting that certain roles are inherently gendered, and this might take some, reworking our thoughts about who can complete certain or who fits certain job descriptions. So Walter used the example of pushback when it comes to hiring female drivers in Zimbabwe. And he noted that there were several women in leadership positions, but there was just something about this role that seemed to be inherently more male oriented. So it took some conversations about, kind of figuring out why that was in order to move towards a solution. And then Clarence brought up the really important factor that when it comes to GESI integration, it all exists within a system. We discussed stigma towards male mental health and specifically seeking out therapy or stating that one has a problem that they need help with because of views of men in Zimbabwe being providers or fixers. So noting the fact that in order to create more inclusion for men in the workplace so that they can, share when they're having issues in the workplace or when they've experienced abuse in the workplace, is to create a more inclusive culture in general. So kind of similar to what Tiffany was addressing towards the end.
And I'm really sad to see time flew by so fast, and we still have a lot more to say. But I would like to encourage people to apply for the 3-part virtual workshop, skills building workshop that will be focusing on the foundations of GESI and GESI integration and mainstreaming. So the link to that application is provided in the chat, and please register, apply for that virtual workshop, and we look forward to continuing this discussion on the IAPHL platform and other platforms. But before we close, I would like to introduce Kelly Hamblin from BMGF. She's going to give us the closing remarks. Kelly is a Senior Program Officer in the Immunization PST, focusing on supply chain, including visibility and cold chain. Her work includes close partnership with Gavi, UNICEF, WHO, and an expanded set of technical partners and innovators to think through improved supply chain and cold chain design operations. She also represents the foundation in global collaboration efforts to enable verification and traceability access across product categories and to expand supply chain visibility to ensure global and local supply meets demand. Over to you, Kelly.
Thanks so much. And thank you for the opportunity to have been able to join today and to participate in the discussion and hear how this is the dialogue, how it's been going. It's been really nice to see. So appreciate the opportunity here. I think on reflection and hearing the discussion that we've had, as I try to kind of distill it, I think that the primary takeaway that I've had is that when we talk about gender and the implications of it, in particular as it relates to all of our work in global health, it really comes down to a pretty important point around power and where that power lies. I think that power could be related to where one is in as a position of authority, and whether women or men are typically in that role. It could be, I really appreciated Yasmin talking about time poverty as well, like the power to even decide how you're spending your time, or perhaps because there are many other obligations that you don't have a lot of time, resources, like the decision-making power for many households may not lie with the woman of the household. And so then what mandate do they have to make important decisions? So I really think when it comes to thinking about gender in particular in global health, it's where that allocation of power is. And I think the place where that matters to us in particular in supply chain is how we're deciding how our programs are designed and who has voice where. And in thinking through that, one example that rings very true for me is I was joining a colleague at a national logistics working group meeting, and everyone at the table, with the exception of me as a visiting donor power, white power woman, I was the only woman sitting at the table. There were many people who were in the background who were women, but none of them were actually sitting at the table. And so I actually asked, because I did have that power, to I asked one of the women that were there to join me and sit next to me at the table. And I guess that's what my ask is in the last few minutes that we have here, that we all have powers in different ways. And if there is an opportunity for you to use that to bring others along, if perhaps one is a man in a powerful situation, or if you're even a woman and you happen to be fortunate enough to be in that role, that you have the ability to bring others up with you, because that's the ability that we have in that position. So, and then finally, just like one last thought, as recently reading through the Global Health, a Global Health 50/50 report, which is talking about gender inequity. I think this was actually related to the COVID rollout, and it really speaks to this kind of like distinction of where we are with power, is that the decision making about where products are being distributed in the response for COVID were primarily sitting with men who were in leadership positions, and the people who were actually administrating vaccines were women. And because they were the kind of extension health workers, and they're often low paid, and like that distinction there of like those who were doing the work and then those who were making the decisions. And often you don't see. I think that the quote that really resonated with me was that the only time that you see a woman is when she's the vaccinator and she has no say in the delivery. And so, like, to reflect on that a little bit about like who actually has a say in how our systems are designed and distributed, and how we can make sure intentionally that they have that we've thought pretty carefully about how that design is impacting the people who are using it. That's the role that we have as supply chain practitioners in global health. So just kind of wanted to make sure that it was clear that this isn't just about like how we design programs and how they're implemented, but there's an individual component of that as well. And kind of leave you all with that as you take the rest of your day or start the evening that you have. And really, again, appreciate the time for all of you inviting me, and thanks again.
Thank you very much, Kelly, and Taroub and Yasmin and all the other contributors. We really appreciate your time. Participants as well, we thank you for your engagement, and we look forward to hearing from you and discussing more with you in the future. Thank you. Have a good evening.
Thank you, everybody.
Thank you so much, everyone.